The Emory Medical Television Network and the Department of Medicine, Emory University School of Medicine, present Medical Grand Rounds.
Welcome to Medical Grand Rounds. Today we have the good fortune of having a speaker who's well known across the world, and to introduce the topic and the speaker, Dr. Jerry Fletcher.
Thank you, David. We're happy today to have Dr. William Roberts with us. Dr. Roberts is a native of Atlanta, went to Grady High School here a few years ago, moved on out west to Southern Methodist University for college, graduation, and back to Emory for medical school. Subsequently, he moved up sort of northeast to spend some time on the OSHA service at Johns Hopkins, time in catheterization laboratory with the National Institutes of Health, and a variable background from the standpoint of being a good doctor type training on to his particular interests, which have been in pathology, specifically pathology of the heart. Bill has published widely, as all of you know, in many areas of cardiac pathology, and probably has looked at more hearts on his side of the table than anyone in the world. We're very pleased to have him with us. His writings, I think, continue to be attractive to all of us. He's editor of several books, and probably his most current one, Cardiology 1982, who collaborates with Drs. Mason, Engel, and Kahn, which give you the perspective of his relationships to other people, not just as a hardcore pathologist, but various inputs into medicine. Today's topic will be sudden cardiac death, and Bill, turned over to you now for Medical Grand Rounds.
Thank you very much, Dr. Fletcher. It's a treat to be back here. I appreciate those kind words. It's really nice to be home, I assure you that. Go ahead with the first slide. This has to do with sudden cardiovascular death. As you know, maybe the darker the better. This is a very busy slide, of course, but I show it simply to point out or to emphasize that sudden death can be a very complex situation. I think most of us, when we think of sudden death, think of the coronary route here, and primarily atherosclerotic coronary heart disease. Usually it's without myocardial infarction, of course, but there are many other causes. There are non-atherosclerotic causes of coronary sudden death, isolated dissection, embolism, and various coronary anomalies. Of the non-coronary causes, certainly a valvular heart disease is in the group, and primarily the obstructive lesions rather than the purely incompetent lesions. Of the cardiomyopathies, hypertrophic cardiomyopathy, the most common, but a few patients with dilated cardiomyopathy, as you know, may die suddenly without some pre-existing problems. Of the secondary cardiomyopathies, sarcoid would be number one, I think. Amyloid, about 5 or 10% of the patients we've seen with cardiac amyloidosis have died suddenly, and that may have been their first manifestation of cardiac disease. Myocarditis, dieting, a few congenital anomalies, pericardial disease, very rare as a cause of sudden death. And then there are many vascular, non-cardiac, but vascular causes involving aorta or any other type of artery. My purpose here will be to look in more detail at some of these features. Now, first, coronary atherosclerotic type of heart disease. I think it's important for all of us to realize that we get plaques in our coronary arteries when we reside in the lipid-laden environs in which we do. But how much plaque can we get without any problem? And discussing this with a number of engineers, it seems as if at least 75% of the lumen of the artery must be occluded in cross-sectional area in order to diminish flow. That means we can fill up nearly 75% of our coronary bed and still be free of evidences of myocardial ischemia. To emphasize that point, if we look at C here, patients who die suddenly or with any other types of coronary fatal atherosclerotic heart disease, at least 2 of these 3 major arteries, if we eliminate the left main for a moment, are narrowed greater than 75%. There are very, very few exceptions to that. I think this is true for symptomatic coronary disease as well as fatal. I know it's true for fatal. So we can fill up 75% of the lumens of our arteries and still be home free. We can occlude one artery completely or nearly so and usually be home free as long as that occlusion is relatively slow. But it's when 2 of these 3 arteries are severely narrowed, that's when we have trouble. And that's in sudden death or acute myocardial infarction or any of the subtypes. We studied a group of patients who fulfill this definition of sudden coronary atherosclerotic death a few years ago. Sudden death, of course, is relatively easy. I had a trip to the Soviet Union a few years back, and my neighbor asked me, "Why are you going to Russia?" And I said, "Well, I'm on a delegation to study sudden death." He said, "You couldn't have picked a better place to go." But of course, he was not talking about sudden coronary death. And from a coronary atherosclerotic standpoint, I think that at least one of the arteries has to be narrowed greater than 75%, or one cannot attribute the death to coronary atherosclerotic disease. Now, how much narrowing is present in these patients dying suddenly from coronary atherosclerotic heart disease? Well, the first couple of slides had to do with the maximal degrees of narrowing in any of these 3 arteries. But really, that's a qualitative type of analysis and provides insufficient information in the at least quantitative period we live in today. So what we, my colleagues and myself, have been doing the last 3 years or so is divide these 4 major arteries into 5-millimeter segments. Now, normally the right coronary artery is about 10 centimeters long in the average adult. The left main is about 1 centimeter. The left anterior descending is about 10 centimeters, and the left circumflex gets pretty small after about 6 centimeters. Now, that in total is 27 centimeters. If we divide each centimeter into 2 5-millimeter segments, that provides about 54 5-millimeter segments to look at, and we prepare a histologic section from each 5-millimeter segment. Now, this percent number here is the percent of those 5-millimeter segments, namely out of 54, that are narrowed 76 to 100%. So in the typical patient with sudden coronary death, and this is based on 31 patients, 36% of that coronary tree is narrowed to that extent. Another 34% is narrowed 51 to 75%, a total of 70% of these 4 major arteries narrowed greater than 50% in cross-sectional area. A number of years back, I was taught that coronary atherosclerosis was a focal process among patients with symptomatic coronary disease. To believe that really is to believe a myth, I think, because only 7% of these segments were narrowed 25% or less, and virtually none of them were entirely normal. Now, acute myocardial infarction is not really in the category of sudden coronary death. Occasionally, a patient with acute myocardial infarction presents with a complication of infarction, for example, rupture of the free wall, and that causes sudden death. But I would not, as a rule, put these patients in the category of sudden coronary death. But it is interesting that the amount of narrowing of these 5 mm segments in the acute myocardial infarction group is identical to those in the sudden coronary death group. 34% of the segments were narrowed 76 to 100% by atherosclerotic plaque alone, 38%, 51 to 75%. Now here's a group, of course, who made it to the coronary care unit. The first group never made it to the hospital. And yet the amount of narrowing by atherosclerotic plaque is similar. One of the reasons we got into this quantitative type work was to try to put a handle on why one patient with coronary disease had angina pectoris, another acute myocardial infarction, another so-called sudden coronary death. The answer does not appear to reside in the status of the coronary arteries. Actually, the angina group, we studied 22 patients with unstable angina. This number down here in that group was 47%, and myocardial function in them was normal. Well, this slide summarizes these observations in these patients with sudden death and acute myocardial infarction and compares the findings to other subsets. Of the whole total, there were 129 patients, nearly 6,500 5 mm segments examined, and 35% of them were narrowed 76 to 100%. Another 36% narrowed 51 to 75%, and only 8%, 25% or less. We had controls for this study, and only 3% of the segments were narrowed 76 to 100%, and in none of those patients was more than one artery narrowed greater than 75%. The amount of severe narrowing in the sudden death group, acute myocardial infarction group, was similar. The patients with healed myocardial infarction, I didn't go into that, had a little less severe narrowing, and the patients with angina pectoris had the worst narrowing of all. These were unstable angina patients who underwent bypass operation for angina alone. Now this slide attempts to put a single number or percent for each 5 mm segment in each patient with fatal coronary disease whom we have studied. And what this shows is that the average 5 mm segment out of 54 per patient, among these patients with fatal coronary heart disease, be it sudden death, acute myocardial infarction, or whatever, 67% of the lumen was obliterated by plaque. The control group, only 32%, so about 2 to 1. I think this diagram is important to keep in mind the next time one looks at a coronary angiogram, because the angiogram, the contrast material is in this area, of course, not in this area. Well, running, exercise, we have studied 5 adults aged 40 to 53, actually a couple more now, who were conditioned runners and had no evidence of myocardial ischemia before they became conditioned runners, and they died suddenly while running. It is important, I think, that they were all 40 years of age or older. They had all run for at least 1 year. The longest was 10 years. This patient did almost 110 miles a week. These two were marathoners. 3 of the 5 had strong family histories of coronary heart disease and other family members. This patient developed angina after he had been running for 9 years, but none prior to running. I think it's important that all had elevated cholesterol levels. I think exercise, running is wonderful. I try to do a little of it myself, but if one's cholesterol level is in that category, running is not going to prevent fatal coronary heart disease. Now, out of these 5, 2 through 6 runners, the numbers of the 3 coronary arteries narrowed greater than 75%, and I mean the right, the left anterior descending, the left circumflex. In all 5, each of the 3 arteries were narrowed greater than 75%. In 3 of the patients, we had the entire coronary tree to examine by this 5 mm segment type procedure. And of them, 50% of the segments, 56 and 34% of the segments were narrowed greater than 75%. This is the proximal on the top panel and the distal on the lower panel of the right, left anterior descending, and left circumflex coronary arteries in one of those runners, a 49-year-old man who had participated in about 6 or 8 marathons. He ran 110 miles a week, and he developed angina only a year before he died. And that was while running, usually in his first mile, and then he would slow down, it would go away, and then he would continue his 20-mile run. But look at those coronary arteries. Very, very narrowed lumens. I'll get in a while causes of death in patients under 40, or particularly under 30, during athletic events. But this was one patient we had an opportunity to study the heart. This was a National Football League player who died during a National Football League game. And he died suddenly, of course, in severe coronary atherosclerosis. History came out after death, and these were his arteries. Great deal of hemorrhage into these arteries. I think, obviously, most people with playing football have clean coronary arteries, and they can accept these blows very readily. But if one has calcified plaques and so on in these coronary arteries, it potentially could cause a great deal of hemorrhage into these plaques. And this patient clearly had a fantastic amount of blood extravasated into the plaques. He was 27 years old. One of the things that I suspect some of you are seeing today is the asymptomatic cardiac patient, or asymptomatic at rest, because of 25 million runners or joggers in this country, that maybe the symptoms are occurring a little bit sooner than they might otherwise have occurred. We've seen several patients now in necropsy where the arrow went this way and chest pain and arrhythmia occurred during exercise, others where only arrhythmia or dyspnea occurred. A couple of these patients turned out to have amyloid or heart disease and non-coronary type affairs. There are obviously a lot of medico-legal problems, work compensation situations, when one starts discussing a sudden death. A couple of weeks ago, I gave a talk at Georgetown Law School. I thought I would never do anything like that on a sudden death. But this is one thing, of course, that the lawyers are very interested in. And it comes up fairly frequently that someone who dies suddenly or has died suddenly, particularly if it occurred at work, was there a stressful situation at the time that the fatal cardiac arrest occurred? My view on this is that I have never seen a stressful event associated with sudden death if the heart anatomically was entirely normal. The usual situation, of course, is that the coronary arteries are narrowed, and whether the heart is big or normal size, as long as the coronary arteries are narrowed, this situation can occur. In recent years, I've seen several patients in necropsy now who had entirely normal coronary arteries, but a very large heart from systemic hypertension. So I'm convinced that maybe a stressful event in a large heart can precipitate sudden death. These are typical cases that might arise in the courts, and I think that many of you will be asked to give depositions as time goes along on these type of cases. This particular fellow was a 44-year-old taxi driver, was well until about an hour before he died, when he became enraged because his taxi was bombarded by snowballs thrown by 3 youths. One snowball entered an open window and hit him in the face, knocking off his glasses. He immediately radioed the police, who arrived several minutes later and apprehended the youths. The police described the driver as livid with rage over the incident and advised him to leave the scene. 30 minutes later, he radioed his dispatcher he was having breathing difficulties. He arrived at the dispatcher's office a few minutes later and collapsed and could not be resuscitated. At necropsy, each of the 3 major coronary arteries were severely narrowed by atherosclerotic plaque. The myocardium was normal, and the heart was at the upper limits of normal. Now, I would think with a heart of that size, if his coronary arteries had not been severely narrowed, that I don't care how livid with rage he became, he would not have had cardiac arrest. Here's another situation. This 60-year-old man, a school teacher, had been well all his life except for recognized systemic hypertension, until a few minutes before death, when he became enraged when trying to prevent 2 students in his gym class from fighting. He finally broke up the fight, and while walking away from the event minutes later, collapsed and died. Necropsy disclosed the lumens of his major coronary arteries to be free of significant narrowing, but the heart was quite enlarged, 530 grams. The myocardium was normal. George Engel, who's a psychiatrist at Yale, has described 8 life settings, stressful situations, where sudden death may occur. And these are sort of interesting because most of the time one can fit a sudden death victim into at least one of these categories. All 8 are characterized by these 2 common factors. They involve events impossible for the victim to ignore, and the response is overwhelming excitation or giving up or both. But no matter what these life settings, in my view, which is only one opinion, of course, unless the coronary arteries are severely narrowed, or unless the heart rate is considerably increased over what it should be, sudden death or cardiac arrest should not occur. Now, what this is a dissection limited to a coronary artery. This is blood in the outer media, and you can see that it has considerably narrowed the lumen of the proximal portion of this left anterior descending artery. This was a young lady, 23, who was running for a bus, suddenly collapsed, and that was it. And at necropsy, there was no dissection in aorta, but the LAD was dissected completely, this diagonal and left circumflex. The point of that is that no one can guess about the cause of sudden death unless a necropsy, an autopsy, is done. And to assume that death is that you know precisely what the cause is without an autopsy, you simply can't do that. There are too many surprises. This is a heart of a patient we recently studied, had a silent but massive pulmonary embolism. His Fosso Valley region was open. Some of that clot, after being plugged up here, came across to the left side of the heart, went down the coronary artery like this, and bam, a sudden death. Of course, that could never have been predicted without an autopsy. Coronary spasm, this comes up a lot. Does spasm in a normal coronary artery produce sudden death? My viewpoint on that is no. Spasm may produce pain, but it does not kill, and furthermore, it does not produce myocardial necrosis. We've studied 3 patients at necropsy recently with Prince-Metal's variant angina. This slide summarizes observations in those 3 patients, age 32, 57, and 61. All 3 died suddenly, had clean documentation of Prince-Metal's, of spasm by angiogram. Now, in this, this information right here, I think, is important. This shows the maximum degree of narrowing by fixed lesions in each of these 3 patients. And you can see 0 to 25%, this is diameter reduction, is virtually normal coronary arteries. This one patient had 2 arteries which were narrowed up to 50% in diameter. Now, at necropsy, after sudden death, look at the amount of narrowing in these coronary arteries. Here, virtually none angiographically. At necropsy, 76 to 95% cross-sectional area in that artery, same here. In this artery, in this patient, 76 to 100%. Not quite significant here, but certainly some. And this patient had quite a bit of coronary narrowing, particularly in the artery which had the spasm. All of the ones that had spasm in it at necropsy had quite a bit of narrowing. Now, this slide represents 5-millimeter sections of the left anterior descending coronary artery in this 32-year-old lady with characteristic Prince-Metal's angina. And here at angiogram, 78 days before sudden death, this artery was considered normal angiographically. Now look at these histologic sections. Maybe that's not significant narrowing there, but I suspect this is. Possibly down here, one is getting close to the point of significant narrowing. Now, the point of this is that I wouldn't assume that Prince-Metal's angina with angiographically coronary arteries can cause sudden death. I would think that it can't unless there is still underlying significant coronary atherosclerosis, and that was the situation, at least in the 3 patients that we've studied. Now, coronary anomalies, congenital anomalies, also may be associated with sudden death. The first one of these that was so found was when both the left main and right coronary arteries arise from the left sinus. Now, this looks like an innocuous little anomaly. The first time that I ran across this was in a 19-year-old Naval Academy student, a track star, who had just finished a 440-yard dash. He sat down, collapsed, and that was it. And I was told when I saw the heart that 14 people had seen that heart and found no abnormality. And I luckily just happened to look at the origins of these coronary arteries and see that their origin was not quite right. But subsequently, we've seen several young people in whom this little anomaly was associated with sudden death. Now, it has been believed for years that when both coronary arteries arise from the right sinus and the left main passes between the pulmonary trunk and aorta, well, this one is the one, I'm sorry, that through the years has been thought to have no consequence. However, when the left main passes between these 2 arteries and both arise from the right sinus of Valsalva, this has been documented to be associated with sudden death. The mechanism is thought to be this. The sudden deaths have occurred during exercise or immediately thereafter. And it has been proposed that the pulmonary trunk and aorta dilate as the cardiac output goes up with exercise, and possibly that squeezes that artery a little bit, or possibly the angle of the ostium from the aorta is abnormal. But at any rate, it's associated with sudden death, but a clue possibly is syncope, which occurs in some of these patients. Now recently, we've seen 4 individuals in whom both coronary arteries arose from the right sinus. And this is the one that historically has thought to be unassociated with any cardiovascular consequences. But I'm not sure that's the case. These are the patients we've seen with origin of the right coronary artery from the left sinus. We've seen one additional one recently. But these 3 individuals died suddenly, and the only abnormality found at necropsy was this coronary anomaly. In these patients, the anomaly appeared not to have caused any trouble during life. Now, there was a paper appearing from Miami about 3 years ago suggesting that tunneling of a coronary artery, that is, a major trunk being within myocardium over a certain length, could be associated with sudden death. 3 patients were described, all of whom died suddenly during exercise. I would point out that whenever an artery tunnels in myocardium, that the artery is free of atherosclerotic plaque. This is the usual situation. Tunneling occurs of the left anterior descending in at least 20% of us. It occurs in the first diagonal, the obtuse marginals, probably in the same percentage. It may even occur on very rare occasion in the left circumflex and the right, with the atrial myocardium flipping over the artery. This is a sort of an interesting situation where there was severe atherosclerosis in this left coronary artery, terribly narrowed. The tunnel portion was absolutely free of plaque. It came out from beneath the myocardial bridge, terrible atherosclerosis again. What we all need is to tunnel our major trunks, and we'd be home free. One of the arguments that I would use to suggest that tunneling is of no clinical consequence is this situation. We've seen 2 patients at necropsy in the last 3 months in whom the left main coronary artery arose jointly with the right coronary artery from the right sinus and burrowed within the ventricular septum to come out just anterior to the septum and then divide into the left anterior descending left circumflex. Now, the point of this is that here is the left main coronary artery, or the supplier of 2 major arteries. And the length of this tunnel in one of the patients was 5 centimeters, and in the other one, 4.5 centimeters. Yes, both of these patients died suddenly, but the reason they died suddenly is that they were shot in the head by a pistol. I doubt if tunneling ever, in my opinion, causes any trouble. Now, we all know that severe narrowing of the left main coronary artery is a bad lesion to have. I show this diagram to point out that that left main coronary artery may be atretic from the time of birth. And this diagram was prepared from a 63-year-old man who died suddenly, but he died not because of this atresia, but because of severe atherosclerosis over his entire coronary tree. One may have normal coronary arteries, but with aortitis or some other type of lesion which causes narrowing of the coronary ostia, sudden death may be one of the consequences. This is particularly true in patients with type 2 homozygous hyperlipoproteinemia, or Takayasu's arteritis. Now, we all know about the mitral valve prolapse being associated on rare occasion with sudden death. Obviously, it's extremely uncommon, but it does occur occasionally. I've seen one patient who had 3 clicks and no murmur die suddenly at necropsy. Seen a couple of patients in this category with a click as well as a late systolic murmur. Sudden death in this category is the least frequent of all. Now, this is a typical example of a floppy prolapse mitral valve. This man was 46 years old, had been studied at the Naval Hospital in Washington, had prolapse by every procedure known, including auscultation. Tricuspid valve is also floppy. He was at a dance one night, just finished a jitterbug, sat down, collapsed, that was it. The floppy valve was the only thing seen. I've seen 2 patients now at necropsy, relatively young children, who had severe aortic regurgitation from the time of birth, from a so-called tunnel, anomalous channel between aorta and left ventricle. And both of these children died suddenly. I think most of us tend to think that it's the obstructive lesions, like aortic stenosis, usually associated with sudden death, but some of the purely regurgitant lesions may also. In my experience, aortic stenosis, although described frequently as one of the cardiovascular lesions associated with sudden death, it's been very uncommon in my experience. I've seen this a little more often, actually, a double valve replacement, but the poppet here is gone. It was found in the abdominal aorta. This fellow was standing up in church singing a song, and suddenly he wasn't standing any longer. There are always surprises virtually at necropsy. Here is a heart of a patient who was walking around Washington, D.C. area, healthy, presumably, died suddenly on the streets. Necropsy was done, found this large cancer in the left atrium, virtually occluded, appeared to obstruct in some way the mitral orifice here. He had a large carcinoma of the lung, which grew into the pulmonary veins and appeared here. Hypertrophic cardiomyopathy, that's what this picture is. This belonged to a boy who was 15 years old. He was playing in the woods, jumped over a fence, collapsed, that was it. The family had 5 sons. 4 of them died suddenly from hypertrophic cardiomyopathy. We would certainly call this malignant hypertrophic cardiomyopathy. But that's one of the more common causes of sudden death, and possibly the most common cause of sudden death in patients under 30, under 25. Dilated cardiomyopathy, I used to think this was a very uncommon cause of sudden death, but we recently reviewed 150 necropsy patients with dilated, idiopathic dilated cardiomyopathy, and lo and behold, 25% of them died suddenly. Myocarditis, in my experience, a very uncommon situation, at least as inflammation limited to the heart. This picture was taken from the heart of a 24-year-old soldier who was playing basketball and suddenly collapsed. At necropsy, he had inflammatory cells all over his myocardium. So on rare occasion, myocarditis is a cause of death. Now this heart, not a very good picture, but this belonged to a man who was 28, a construction worker. He was carrying a load of bricks and a wheelbarrow across a construction site, suddenly collapsed, and that was it. Necropsy was done, and sarcoid granuloma all over his myocardium. So this is an example of sarcoidosis presenting as sudden death. We've studied 28 patients with cardiac sarcoidosis a few years back. 17 of them died suddenly. And in 5 of those patients, sudden death was the initial manifestation of their sarcoidosis. This reviews previously reported patients with cardiac sarcoidosis and the types of arrhythmias and conduction disturbances that one might see. They're primarily, of course, ventricular arrhythmias, ventricular tachycardia, ventricular premature complexes, complete heart block. Atrial arrhythmias are far less common. The 25-year-old who suddenly has complete heart block or suddenly develops episodes of ventricular tachycardia, one has to suspect sarcoidosis. It's an interesting situation, I think, and that is patients with symptomatic cardiac sarcoidosis, or those who die from it, tend to have symptoms limited to the cardiovascular system. One, in other words, tends to go down the cardiac sarcoid road or the non-cardiac road, and there's relatively little overlap between the two. Now, this is a very sad situation. This was the heart of a young boy, 16, who was swimming at the beach. He waved to his parents on the shore, and then a few minutes later, and perfectly okay, a few minutes later, his body washed into shore. Well, what caused his death? The heart weighed 400 grams. Now, that's a little big for a 16-year-old boy. Any way you want to look at it. The septum really is about the same thickness as the free wall, so I would not call this hypertrophic cardiomyopathy, but it's clearly a cardiomegaly. He had no evidence of systemic hypertension. We looked at his artery to his sinus node and other portions of his conduction system, and lo and behold, that sinus node artery is quite small, quite narrowed, very thick wall, and myocardial fibers around the sinus node artery contain calcific deposits. Now, clearly, this is very abnormal for a 16-year-old boy, and we've seen 3 patients like this. Sudden death, sinus node artery is big, is thick walled, narrowed lumen, and some of these surrounding myocardial fibers are clearly abnormal. I don't know what this means, but it's clearly a cardiovascular disease. A few years back, the CDC here in Atlanta allowed my colleague Jeff Isner and I to become involved in study of some of those patients who were on the low-protein modified fast diet, and we had access to autopsy-type tissues in 16 of them. Now, the average age of this group was 37. They all died suddenly. Ventricular tachycardia occurred in all of the ones who had adequate electrocardiograms, and the QT interval was prolonged in all of them. This is a situation where they lost, in an average of 5 months, 35% of their pre-dieting body weight. In other words, these patients were the superstars of their diet clinic, and yet they died suddenly. And here are the QT intervals, all abnormal in those electrocardiograms. So vigorous dieting with massive weight loss over a short period of time, one should probably follow these patients, at least with electrocardiograms. Now, there are vascular causes, aortic causes of sudden death, of course. This is the Marfan syndrome. You can get an idea how big that aneurysm is by knowing that this is the right coronary artery and that's the left main. When we look on the inside of that, this is a tear right here. This is sudden death due to rupture of this aneurysm from Marfan syndrome. We studied 2 Maryland basketball players, both of whom died suddenly 2 years ago. They were both on the varsity, both first team. One had the Marfan syndrome with rupture of the aorta. The other had hypertrophic cardiomyopathy. We've studied 18 patients with the Marfan syndrome at necropsy, and rupture of the ascending aorta occurs occasionally. A dissection occurred in 3 of these patients. Now, this is an unusual situation. This heart belonged to a lady, 33 years old, who was vacuuming her house, and all of a sudden she collapsed, and that was it. Necropsy was done, and the pericardial sac was filled with blood, and this is a sinus of Valsalva aneurysm, which ruptured right through there. Now, usually these rupture within the heart, but occasionally outside the heart. Dissection of the aorta. One very prominent citizen in Washington, D.C., went to a Redskin football game a couple of years ago, came back home feeling well, opened the door, and said, oh, she collapsed. She told her husband, no, this is not my heart, and that was it. This was a dissection of the aorta, ruptured in the pericardial sac, and that clearly at times is a cause of sudden death. The aorta, the superhighway of the vascular system, may pop from many causes, of course. This was a patient with syphilis, big aneurysm, ascending aorta, pop, sudden death. This particular patient was found with blood gushing from her mouth with the same heart rate as her heartbeat. And here we have a situation where the aorta ruptured due to really an inflammatory process into the esophagus, and 70 times a minute it was coming out. Trauma. 900 people in this country, as you know, die from automobile accidents each year. Some of them involve the aorta, and when that occurs, it's usually the descending thoracic aorta, the tear right at the aortic isthmus. Causes of sudden death in competitive athletes. Dr. Barry Marin and I have been reading the sports section for the past 4 or 5 years. I forgot to take that off my income tax. I just thought about that, as a matter of fact. But we were looking for competitive athletes who died suddenly, and at that time studied 29 patients. That's up to 34 now. Their ages were 13 to 31. If one looks at a group over age 40, it's coronary atherosclerotic disease. But under age 40, hypertrophic cardiomyopathy was 15 out of the 34. That was the most common. Left ventricular hypertrophy, cause is unclear, was next. Atherosclerotic coronary disease, 3. And then these congenital anomalies. Origin of the left main coronary artery from the right sinus. Origin of the right coronary artery from the left sinus. Hypoplastic right and left coronary arteries. Cardiac sarcoidosis. Ascending aortic rupture. And in 3 patients, autopsies were done, and there were no clear, distinct, unequivocal causes of death, at least anatomically. If we look at that from a myocardial, coronary, aorta, and uncertain category, the myocardial problems are the most frequent in this younger group. And finally, trauma. In Washington, D.C., of course, we see a great deal of this, a lot of knives, handguns, 900 automobile deaths a week, 10,000 Americans murdered with handguns each year. Something like 35 million handguns have been added in this country since John Kennedy's death. And to summarize, sudden death is simple or complex, depending on how one looks at it. There are many causes, cardiac as well as non-cardiac. And of the cardiac, not everyone is coronary. Some are non-coronary. But of the coronary ones, of course, atherosclerotic is the most common, but there are many non-atherosclerotic types. Valvular disease among the non-coronary, cardiomyopathy, congenital, pericardial, etc. I would like to emphasize that in our era, autopsies, of course, are diminishing in frequency. But if one wants to study sudden death and the causes thereof, one cannot do it without autopsies. Thank you very much. Okay.
Dr. Roberts is a recent recipient of the Gifted Teacher of the Year Award with the American College of Cardiology, and I think this portrays the reason why. Bill, we have a few minutes. I'm sure there are some questions. Please use the microphone, yes.
Yeah, in some of the patients you described, the athletes who experience sudden death after running the race or after the marathon or after the football game, most of those patients you might expect for the death to occur during the height of the excitement or when cardiac output would be the greatest. How do you explain those events occurring sometime removed from the activity?
It's a good question. I don't know the answer to it. I don't know. What's your viewpoint?
I don't know. That's why I asked.
I don't know either.
Dr. Lutz.
Bill, a 30-year-old man has had an acute anterior and apical myocardial infarction, and angiographically he's just got vessels that are as big as garden hoses and look just as smooth as they can possibly be. What caused the infarction?
What was the interval between the onset of the infarction and the angiographic study?
Several weeks, 2 weeks, 10 days.
Well, that's the hooker. As far as I'm concerned, nobody has clearly demonstrated an angiographically normal corneal arterial tree at the time of acute myocardial infarction. These studies through the years have entitled something such as myocardial infarction and angiographically normal corneal arteries. Not a single one of those studies, and in the 70s this was a popular subject, was the angiographic study done at the time of infarction. There are 5 exceptions to that, and that is infarcts which were precipitated at the time of acute myocardial infarction. And in those 5 patients, angiograms were done and the artery was obstructed. The other major ones were clean. And then in those 5 patients, they were taken back to the cardiac catheterization laboratory after certain degrees of healing of the infarction, anywhere from about 26 days to 2 months. And those arteries which were found at the time of infarction to be totally occluded were totally patent, were wide open. They looked normal. They looked just like the other major arteries. So I would assume that most of those patients are having a clot, I presume an embolus, at the time that's the item that is precipitating that infarction, but that clot is either recanalizing or lysing, so that later it's angiographically normal.
Other comments?
Maybe about 10 days. Pulmonary infarcts will clots in the pulmonary tree can lyse completely just in a matter of very few days.
I was wondering if anyone knew anything about the genetics of the coronary artery anatomic abnormalities. So if a family had a young child that was discovered to have one of these abnormalities at post, would you consider doing anything about the other sieves?
Yeah. Well, that's a good question, too. These things are so rare, as you know, that I would certainly think that, number one, there's no information on it. I know of none. I've never read a paper on that subject. The corneal arteries may be a little abnormal in patients with bicuspid aortic valves, and occasionally that can go in families. But these isolated coronary anomalies, I've never heard of them in families.
Yes.
Obviously, in your experience, you haven't shown a protective effect of marathon running on coronary artery disease, but is there any serial study showing regression of coronary artery lesions prior to death in the patients that you've studied?
Well, the problem with that is you can't do an autopsy but once.
I mean angiographically and then compare angiographic lesions with...
Well, there's a study that you probably know better than I on renal arteries. A renal artery obstruction, and the patient was put on such and such diet or medication. Repeat angiographic study a year or so later, and the arteries were more open. That particular one I'm thinking about was in the American Journal of Medicine a couple of years ago. Coronary regression, a regression of atherosclerotic plaques in the coronary system, clearly regression has been well documented experimentally. These yellow plaques that are the first lesions to produce be produced experimentally in atherosclerosis are entirely reversible, be it intracellular lipid or extracellular lipid. Robert Whistler in Chicago believes that some of the fibrous plaques are also reversible, and he has some evidence to that extent. I certainly like to think that if one loses 10 centimeters of anterior panniculus, for example, or a lot of body weight, that one is losing a certain percent of that atherosclerotic plaque. The dominant component of atherosclerotic plaques, at least in patients with fatal coronary atherosclerotic disease, is fibrous tissue. But there is a good percent of lipid. And if one believes in the concept that one simply has to get that luminal narrowing to less than 75% from greater than 75%, it seems to me that semi-starvation is the most neglected of all forms of cardiovascular therapy. I don't think marathon running, if your cholesterol is 300 or 400 or 250 or whatever, is going to prevent atherosclerosis, but it sure makes one feel better in the interim. But if one is a marathon runner and that cholesterol is 140 or 130, that person may be here forever.
I think it's the multifactorial that you mentioned, the smoking, proper exercise, diet, weight control. That's all these things may cause some retardation or regression. Dr. Lutz, last question.
I've not seen any. In 23 years, looking at hearts of patients dying of cancer, which I also try to do, I've seen one myocardial infarct. Now, of course, cachexia and fatal cancer is a terrible price to pay for freedom from significant coronary atherosclerosis, but there is evidence, for example, also in World War II, frequency of heart attacks diminished, apparently, during certain countries in World War II, when beef and that kind of thing was not eaten as much.
Skip Johnson had an article several years ago in which he had a young man who was in his early 20s in whom this gentleman had a myocardial infarction. He proved angiographically normal coronary arteries and a response to ergonovine with spasm of the vessels, and a subsequent, I think he had 2 myocardial infarctions after this. I take it you don't feel that they're related?
Well, the way you presented it certainly sounds like they're related.
Well, I was interested because you said that just because somebody has spasm, you don't feel that it causes either myocardial necrosis or sudden death. And
well, I would put
there's
it this way.
anecdotal data.
I haven't seen it. You could argue, well, of course you haven't seen it. You're a pathologist. You don't see spasm. But I have not seen spasm per se documented to produce either myocardial necrosis, namely acute myocardial infarction, or sudden death. Now, 2 of the 3 patients that were presented here today with Prince-Meadows angina and sudden death, had not a necropsy been done, those would have been considered to have had absolutely clean coronary arteries, but yet they weren't.
Bill, thank you. It's always good to have you in Atlanta.
Jerry, thank you. Thank you.
Presented by the Department of Medicine, Emory University School of Medicine. Broadcasting from studios in Grady Memorial Hospital, this is the Emory Medical Television Network, KVI 65 and KVI 66, Atlanta, Georgia.